All right, so when using our cricothyroid models, this is the technique that I wanted to show you guys to start with today. There are multiple techniques for doing a cricothyrotomy. The one I prefer is the scalpel bougie or scalpel finger bougie method. Now, in this method, you're going to make a vertical incision across. You're going to dissect down. You're going to cut across the cricothyroid membrane horizontally. You place your finger in, put in a bougie, and then feed your tube over. It's fast, it's efficient, and prevents you from losing your airway or your position. The equipment that you need, there are many different cric kits and institutionally dependent devices, but the equipment that you need, as we had said in our setup video, a laceration tray will give you hemostats, needle driver, scissors, 11 blade scalpel I prefer, 6/0 tube. Suture is optional for if you want to practice suturing it down, in a bougie. So when you're doing a cric, it's for a patient that is a cannot ventilate, cannot intubate patient. It is an emergency situation. It is very stressful in the real world. And your first one is very, very intense moment, so having lots of practice ahead of time is a wonderful thing. It's best to position yourself on the right side of the patient. If you're right-handed, that way you can take your non-dominant hand, you'll take your hypothenar eminence, place it on the chin. Using your pinky and thumb, you're going to grab the thyroid cartilage, and your index finger or middle finger can be used to palpate the cricoid cartilage right here. And in between, you'll feel the membrane. That way, when you go to do your procedures to make your incision and cut, you'll be holding it in place, pulling the skin down so nothing moves. Okay? So, before you start doing this, in the real setting, one of the wonderful ideas that people have is to decrease dead space for your tiny tube. So a 6/0 tube is a very small tube, but it's not a very big opening that you're going to make, so you're not going to get an 8/0 through it. The 6/0 tube has a lot of excess dead space that's not really needed because you're going straight into the airway, so you don't have to worry about the tube being long enough. The balloon will track up here. You go just above the balloon, and you go ahead and cut your tube. Then you can take the connector off and reconnect up here. By doing this, and doing this before you start your airway, you have a much smaller tube and have eliminated a lot of excess dead space, and it's something that's better to do before you insert it. That way you don't have to worry about ruining your tube or having a problem. Okay? So, when you're ready to do the procedure, and keep in mind, these things do happen very, very rapidly. What you're going to do is you're going to hold in position, feeling the thyroid cartilage, the cricoid cartilage, the area in between. You're going to make a vertical incision. How I tell people this to do this is they go straight down, feel the cartilage, cut in a single motion. Okay? Good. Close your scalpel, and you can take your hemostats and use them to bluntly dissect down to your cricoid membrane, as you can see here. Now, in the real setting, when you're doing this, what's going to happen is you're going to have a fair amount of bleeding. Don't focus on the bleeding while it's happening. When you put in your ET tube, it will tend to tamponade off, and unless you are way off to the side, you're not going to injure the large arteries like the superior thyroid artery. Opening, you can see your membrane. You take your scalpel again. You're going to make a horizontal incision straight across, as you can see. Close, and you can put in your finger to open and dilate. Next to your finger, you feed in the bougie. This should only need to go in a few centimeters, and you should be able to feel the clicks of the tracheal ring. Now, you can quickly feed your tube over your bougie into place. Sometimes you'll need to give it a little twist to put it into place, but it should just slide right in. As soon as the balloon is passed, go ahead and close. pull the bougie out. Stop, inflate your tube, and begin to ventilate. The bleeding should be controlled just by tamponading and having the tube put into place. If there is excess bleeding around the area, you can place figure eights on either side. That can help control the bleeding, and you can also suture it into place. I prefer to suture it in the same way that you would suture a chest tube. Now you can do U-stitches, you can do fancy things, but easily enough, generally if you just suture across here, pull, and do a hand tie, you can generally get a pretty tight fit that will give you a good position and keep the tube from moving around or migrating. Now, one hand tie, two hand tie, instrument tie, it doesn't matter. I prefer to do a one hand tie because I can get a nice easy feel, but obviously the model will jump around a lot more than my patient will. And then from there you can wrap it up like so. Of course the balloon shouldn't be that much in the way. Once more around, your RT will be ventilating. Of course, after you get to sew this down, you get to go change your pants because obviously, as I said, these are very stressful, scary experiences, which is why it's nice to practice. And you cut your sutures, and now your ET tube is in place, inflated. It is a temporary measure, very temporizing, but very effective when needed. Our other model that we have that I show you, the difference while you're doing the technique is that you'll be cutting through something that is taped down. It can be a silicone pad, you can use a Mepilex, but it's going to have you a very similar experience. And like I said, the other one that we have, we're able to take and store all of our equipment for later use. This is one of the two ones we have set up in the resident room. All right, thank you so much.